Respected Director Sir, esteemed dignitaries, distinguished faculty members, honored alumni, invited guests, and dear colleagues and residents, and ladies and gentlemen, a warm welcome to each one of you. It's my great privilege and honor to welcome you to the Golden Jubilee celebration of the Department of Imaging Science and Intervention Technology of Sri Chitra Tirunal for Medical Science and Technology. Today marks a significant milestone as we celebrate 50 years of excellence, 5 decades of innovation, academic distinction, compassionate patient care, and pioneering contribution to the field of imaging science and intervention technology. It is also an occasion to honor the visionaries, teachers, alumni, and countless individuals whose dedication has shaped this department into the institution it is today. We begin today's program with a scientific session titled Interventional Radiology, My Best and Worst Cases. For this, I invite Dr. Anup and Dr. Ginny of Additional Professor of Interventional Radiology to moderate this session.
Alumni, and he's one of the senior faculties in Lisi Hospital. He's doing a wonderful work there. So Dr. Jagshan will be discussing regarding advanced intervention, especially the peripheral vascular disease. So over to you, Jagshan.
So this was a case he did about 4 years back before all the atherectomy devices came into the market of peripheral arterial diseases. So this is a relatively young male, 50-year-old male patient with toe gangrene, severe below the knee peripheral arterial disease. So this was the initial picture which was there for him. So there was significant peripheral arterial disease, predominantly the inframalleolar aspect. There is a very small caliber dorsalis pedis which is faintly filling. Mainly everything is by collaterals to the peroneal artery, and the pedal arch also patent through collaterals, but there is no distal filling of the digital branches. So the very severe small arterial disease. So this patient first underwent one sitting of angioplasty. So after that there was slight improvement in the flow. There was the PTA angioplasty was done. The PTA was crossed with great difficulty for this case, and there was a significant recoil because it was a calcified segment. So basically, to achieve a good recanalization of the PTA in this case, because PTA was the artery which was directly supplying the arch, he had resorted to a scoring balloon with multiple scoring balloon plasties to break the calcium. So after that, this was the final picture obtained after the first angioplasty for the BTK disease. So this looks like a very good post-plasty angiogram. There is good filling distally, the good wound plush is there. So after 2 days, the patient is having severe pain, and he was having severe rest pain. So the repeat angiogram was done for the patient. So again the PTA has gotten occluded, most probably due to a recoil stenosis. So again multiple plasties was done. Same thing, we are achieving the recanalization at that point, but you can see in this angiogram there is still that recoil waste which is there. So most probably this is that area which is again causing the spasm or repeated reocclusions. So the patient again will come back after a few weeks with pain, similar picture. There is the reduced wound vascularity on debridement. So this case was done almost 3 or 4 years back at that time, and there was no atherectomy devices which are available with a proper shaft length to reach an inframalleolar disease or reach till at least the level of the malleolus. So even though preferably it's something which is not to be done in this case, the PTA stenting was done after multiple attempts of balloon and cutting and scoring balloon angioplasty was failed. So after that, the results are again the same. Very good wound blush is achieved, but because it was the stent was deployed at the level of the malleolus, the patient was advised strict bed rest to prevent any kinking or fracture of the stent to allow good ulcer healing. So, but the patient was treated by a surgeon, a podiatric surgeon at a different hospital who advised ambulation after a few days, and the patient again comes back with pain. So patient was taken for another angiogram, the same thing which is happening again, the stent has gotten occluded and the repeat stentoplasty also fails. So finally multiple times, like the only thing which was able to maintain that flow to that pedal arch was just slightly extending with another stent into this, which completely goes against the dictum of most of the peripheral arterial disease, basically mainly the BTK disease management. So again, there is a very bad ulcer. So the patient again coming back after 1 month with an again poor wound healing, poor wound vascularity. So the cycle just keeps on repeating even after stenting, because distal to the stent it's again getting re-stenosed, re-occluded. And the patient also took stem cell injection from another hospital to try better the wound healing rates, but even that failed, and he was taken for a proximal forefoot amputation. So and he was admitted again with the discussion of there was maybe going for a BK amputation, but the patient was very adamant that he did not want to undergo any major amputation. So and he was given multiple options which could avoid maybe a trial of avoid the BK amputation. The only option which came to mind in this case, because even the stents had failed at that point and there was no atherectomy options at that time, was the trial of deep venous arterialization. So the deep venous arterialization is basically just you are creating an anastomosis between an artery and the vein. So distal to that anastomosis you have arterialized flow through the venous system, and there is reversal of flow towards the foot through the venous arch, so that the wound area will get perfused. So basically what is being done for that case is you take a distal plantar venous puncture and a snare will be passed through this plantar vein into the posterior tibial vein, and under fluoroscopic and combined fluoroscopic plus ultrasound guidance you will have you will puncture into the bullseye central point of the snare, and you will have another wire from the PTA to mark the arterial side. So the needle will go through the snare in the vein into the artery, into the arterial lumen, and through the needle the wire will be passed. So the wire has gone through the snare in the vein into the artery, and the snare will, when we are exteriorizing the snare, we get one end of the wire out through the plantar vein, and you can snare the other end of the wire through the arterial axis. So you have an arteriovenous anastomosis created by plastiing across that junction of the artery vein puncture. So this is how that wire reversal is being done. So after that you do plasty of the plasty of the plantar vein to damage the valves. So the valves are something which prevent the downward flow. So you destroy the valves by using cutting balloons or a high pressure balloon plasty to damage the valves. And after that you deploy a stent. Ideally it requires a covered stent placement in the level of the anastomosis, but since there were no covered stents which could go which are flexible enough to take up that location, because the only stent which is known to track that well into a DVA is a Vyban stent, which was not available in India at that time. So a Supera stent was deployed across the anastomosis. So after that this was the angiogram of the post DVA angiogram. So the post DVA angiogram, there is after the anastomosis there is good filling of the venous system extending till the plantar venous arch. But the issue which made one regret this operation will be that because the patient has undergone already a proximal forefoot amputation, the plantar venous arch also is incomplete. So the actual wound site is getting only a minimal flow. So and there were some other branch veins which were also present. So the branch veins, he underwent multiple follow-up angiograms, and some of the branch veins were coiled to divert the maximum amount of blood flow to the wound area. So the deep venous collaterals, which were large enough to take the blood away from the wound area, that was coiled, and but still, because the venous arch was incomplete, there was not much significant improvement of the flow. So following DVA, there was some decrease in the progression of the gangrene. So that gave some sign of hope, and the patient underwent multiple follow-up angiograms, during which the large collaterals were coiled. The proximal collaterals were not coiled in this case, because the proximal collaterals, if you are coiling that might cause thrombosis of the entire circuit, because it will just cause increase in pressure and flow stagnation. So the proximal ones were not coiled, only the ones which were distal, in the distal leg and around the ankle level, were coiled. So, but despite all that, it was done, multiple interventions were done to keep it open, but finally, because the plantar venous arch was not complete, this patient ulcer did not heal satisfactorily enough, and finally he developed a big infection, and because of the ascending infection, he had to undergo BK amputation eventually. And this case was done with the limitations in hardware at that time, and the DVA is relatively new technique even in the West. So even now that the techniques and the hardware are being refined. So, but this was maybe one attempt at DVA Dr. Lijesh has done, but initially it gave some hope that there might be good wound healing, but in this case probably the lack of a good plantar venous arch because of the much proximal forefoot amputation might have been the reason that it failed. And in a situation where we had already stented multiple times at the malleolar level, there was nothing much further to do for the arterial side in this case. So it was almost like a functional desert foot.
So, yeah, excellent case. So this was 5 years done prior. So if the patient has come currently with the latest, because in below intervention, etc., is an area which is fast progress in the last 5-6 years. So how differently would I approach if the patient has come within last 1 or 2 months?
Now the recoil stenosis is at the malleolar level. So
No, if the patient has come initially itself with this ulcer only.
with this ulcer, the calcified vessels, mainly the PTA is supplying the arch. Once we get the PTA open, just to prevent any further recoil stenosis, we can go upfront with an atherectomy, either an orbital atherectomy. It will be the safest thing, less traumatic for a heavily calcified vessel, and the other option will be a rotational atherectomy with jet stream. Laser atherectomy is also another option. So anyway, anything to avoid that inframalleolar or malleolar level stenting. That is the main thing. Otherwise, IVL is also another option. IVL is something which could have been tried, but I think it skipped the thoughts at that point. So,
across that ankle, will you prefer if it's a calcified orbital atherectomy or IVL?
Best will be IVL. IVL.
And how will your technique of the DVA would have changed? Because currently, would you use the same technique or a similar technique or a different?
Only the stent will change. If the wire band becomes available, the stent will change, and the wire band, if you can extend the wire band much below also, because it's a covered stent, that will take care of the valves as well, valves and collaterals also.
And how will you counsel the patient post DVA? Because that's the most difficult part, because the treating podiatrician, the surgeon, and everyone should be in the same page, because the endpoint of DVA is entirely different from endpoint of a revascularization of a forward angioplasty. So, what's the counseling process after you do a DVA?
The patient and the surgeon has to be made aware that the initial 1 to 2 weeks after the DVA, the leg will be severely swollen. There will be an increase in pain. There will be a significant amount of uncontrolled bleeding during debridement, mainly due to the increase in venous pressures and a change in flow dynamics. And also these symptoms are not to be mistaken for any flare-up of the infection or cellulitis, and the patient should not undergo prematurely a BK amputation. So the DVA will take effect only after a couple of months at best. So the patient has to be on aggressive wound management and even on significant pain management also. One thing which is described is even to have a femoral perineural catheter femoral around the sciatic or the femoral nerve to provide analgesia periodically so that the pain will be controlled, and the patient has to be controlled on that, and the follow-up should be at 1 to 2 months to decide on whether the DVA is working or its patient should undergo amputation.
Excellent case, very interesting approach, looked at all options till the end and try to achieve the maximum results. Great work. Any other questions?
It's a described technique. It was initially developed as a open surgical technique when there was no other option. There is no way to achieve an arterialized flow to the foot. Initially developed as a surgical technique to create an anastomosis between artery and vein. Then in Europe and the US, they now started to having off-the-shelf devices which can create these anastomosis endovascularly. So now it's being done in many centers worldwide. So far, no successful case has been done in India, but it is being done worldwide. In this case, that was because the plantar venous arch also was cut during the amputation.
No, that is when you are injecting contrast. So in the natural situation, naturally the shunting will be more. So the augmented pressure will not be there. So how far the distal area or the ischemic area will supplement?
For that periodically you have to do angiograms. You have to coil off the collateral shunting veins so that the flow will get redirected to the ulcer. So multiple follow-up angiograms will have to be done for this. So this is a different case of the similar spectrum, but something which is done very recently. So this is a 77-year-old male with triple vessel disease who was planned for CABG, moderate LV dysfunction, severe carotid artery stenosis, and patient has bilateral peripheral arterial disease, and patient has a very bad leg ulcer which is infected and not healing, and because of that leg ulcer his CABG was getting delayed because the surgeons were concerned that the focus of infection was not getting healed, and that is going to be a concern if the patient is taken up for emergency CABG. And patient has significantly calcified vessels, very tortuous vessels. Even during a diagnostic coronary angiogram, he developed emboli from the arch vessels because you can see it's a severely calcified arch and brachiocephalic vessels. And even from that, he developed a small stroke during the diagnostic coronary angiogram. So it's a very calcified, the aorta also is very calcified, and he has this very bad leg ulcer. So you can see it's almost like a porcelain aorta. The entire infrarenal aorta is also heavily calcified. And there is severe stenosis of the iliac artery as well, ipsilateral, the right side iliac artery as well. The femoral artery is also calcified. So there is very much limitations of getting an arterial access antegrade for the site of the ulcer. So this patient was taken for a peripheral angioplasty to allow for the wound healing prior to CABG. So this is a very relatively high bifurcation. The angulation is also relatively hostile. There is a nodular calcified plaque which is obstructing here, and just to cross this lesion also, there was difficulty in actually maneuvering the wire through that heavily calcified segment into the external iliac artery, so that a plasty can be done and a crossover sheath can be advanced to the affected external iliac artery. Even that could not be done. So to achieve a better support, we tried with a SIM catheter, but the problem was that the SIM catheter itself was not getting formed. The non-hydrophilic SIM catheter, which could not even form its shape here, because the infrarenal aorta was heavily calcified. It was like a coral reef aorta that was not even expanding to accommodate the shape of the SIM catheter. We tried with a hydrophilic yes. So it was done with a hydrophilic SIM catheter, but the hydrophilic SIM catheter did not give any significant support to cross that occlusion, cross that calcified segment. So finally, to achieve even just a crossover access, we punctured that calcified segment of the right common femoral artery with a 21 gauge needle. 21 gauge needle, and passed a overnight wire, try to cross the occlusion from below using the overnight wire and get it into the infrarenal aorta, and from there that wire was snared. The wire was snared from the contralateral axis. So only the needle is kept at the this femoral site, because we don't want to put a large sheath there in the heavily calcified segment. The hemostasis itself will also become an issue. So we have a through and through access through the to a 7 French sheath, and then a needle access through the calcified femoral artery. After snaring, we just did first initially plasty will be done with a 5 mm balloon to break the calcium. So followed by the sheath will be advanced. The sheath will be advanced over the balloon, over the deflating balloon into this segment. So finally we were able to get a crossover sheath into the external iliac artery of the affected side. So now comes the other part. This will be the distal disease. So you can see that the severely calcified SFA very long segment occlusion. BTK disease is relatively mild. So here since we were planning an atherectomy case, we were planning to do atherectomy for this in view of the extensive calcium, and we were suspecting that a stent might not expand well, stent will reocclude, we will not get a good patency of the stent. Just to break the calcium, we thought atherectomy as the upfront option. And for atherectomy, the trick is to go completely intraluminal recanalization and not going subintimally. And for this heavily calcified vessel, each segment we use multiple wires. Mainly for the calcified segment, we have to use the fluoroscopic guidance, but intermittently there will be islands with less calcium. So in that areas, we will use the ultrasound to confirm that we are intraluminal. So with both combined fluoroscopic and external ultrasound guidance, we were able to break this calcium piece by piece and try to cross, and finally we were able to cross the entire segment intraluminally. So this is almost a 45 centimeter occlusion. The patient was a very tall patient. This was around a 45 centimeter occlusion, heavily calcified, which we were able to completely intraluminally cross. So we have crossed the disease segment completely. And then the work gets relatively easier. So basically now the initial pre-dilatation with a 3 mm balloon to take the actual atherectomy device across this calcium, because such a heavy calcium, no atherectomy device is directly going to cross through it, and just trying to break the calcium with the device itself is going to damage the device. So initial just 3 mm balloon dilatation to break the calcium to bring a lumen gain to allow the atherectomy device. But even after the pre-dilatation, when we are doing the atherectomy, when reaching the heavy calcified areas, even in these segments, one of the atherectomy burrs was not working. So we had to take for a second catheter also just to drill across this area. So finally that entire area was atherectomy, following which we went with a low pressure balloon plasty. And this area, because it was severely calcified, we did the atherectomy an extra time just to get a better deposition, a better disruption of the calcium. And since this was a heavily calcified disease and the taking a filter across and any filter getting stuck was another complication we were anticipating. This case was done without a filter. We were using the distal cap of the occlusion as a natural filter. Try and aspirate every debris before crossing the final cap, and then proceeding to breaking the final cap of the occlusion. Then plasty was done. So the relatively good lumen gain was noted and not much recoil happening around the calcified area. So coming to the distal flow after the atherectomy. So there was distal thrashing, there were distal emboli had gone distal there, something which is to be expected when you are doing without a filter. But in this case, we had to do it without a filter. So then we took an aspiration catheter deep into the BTK disease, and after identifying the level of the occlusion, so we were able to aspirate out the thrombus. Basically, it's a mixture of calcium and thrombus, and we were finally able to re-achieve that Villoni revascularization. So this was the pedal arch which was completely filling. So it was just a small chunk of calcium which had gone in, which was aspirated with a penumbra aspiration catheter, and we were able to recanalize that occluded segment. So finally, this was the pedal arch flow which was achieved in that case. Then we did some finishing touch angioplasties. CFA also was plastied. Then the wire axis which we had kept, we converted that to a 5 French femoral axis because we did not want to go higher than 5 French, and because the manual compression was the only way of achieving hemostasis in that calcified segment. Then we did the kissing balloon plasty of the iliac stenosis. Kissing balloon plasty plus kissing iliac stents, and this was the this was the final Doppler which was achieved at the distal plantar level of the distal PTA level, at the plantar arch level. This was the spectrum which was obtained. A similar case in situation to the first case, but the changes in the devices and the developments across time, the management changed significantly. And with this devices, I think for the first case also we might have been able to achieve a better results.
And you manage the complication as well. Only one comment, a lot of, you are saving the patient, but you are like sacrificing your own hand in the radiation field. Try to avoid. We have taught the other way actually.
Again, in this case, which atherectomy you have used? Which type of atherectomy you used?
In this case, rotational atherectomy, jetstream was used.
That's true. Because
Orbital is also a very good option in this case.
yeah. So because this heavily calcified,
yes.
it's better orbital. So why not an IVL in this case other than?
Actually, for a similar case we did just 2 days before this, we tried IVL. The problem was that when the heavy nodular calcium, the IVL balloon on the first inflation itself, the balloon is breaking. So we had to use multiple balloons. So better than using multiple IVL balloons and the cost of that adding up, we thought atherectomy as a single device may be better.
So this IVL was Which Indian made or outside? The IVL
Shockwave.
shock.
Shockwave.
Because the jet streams embolic are larger compared to the other.
Yes. But jet stream has that aspiration also happening at that moment. Orbital does not have the aspiration.
I think in the interest of time, we'll move to the next speaker. I thank Dr. Jayakrishnan for his contribution to this alumni meet. I now invite Dr. Shanta Kumar. He's proud alumni of SCTIMST IS&IR. He joined DM Neurointervention Radiology in 2018, and he's currently working as an assistant professor in JIPMER as an intervention radiologist.
Good morning everyone. I would like to thank the organizers for the opportunity, and it is always extremely pleasurable to present at our own institute. So we'll start with the two cases. First case is a case of a acute carotid blowout where we took a slightly different route to reach the carotid artery, and second case is about ACOM aneurysm coiling where there was a rupture happened and it was managed. So first case is a 40 years old female who presented with a sudden onset, who had a spindle cell neoplasm of thyroid and was on emergency tracheostomy 2 months prior. So she was on tracheostomy and there was a acute profuse bleeding from the tracheostomy site, oral cavities and nasal cavities. On the day of bleeding, when CT angio was taken, there was a pseudoaneurysm there, and there was arterial irregularities noted in the carotid artery. Then next day we arranged for the stent graft. Our plan was to go ahead with the covered stent placement across the pseudoaneurysm. But next day on the angiogram, after arranging the stent graft, we found that the common carotid artery on the right side was completely occluded from the origin. So the stent graft placement was deferred, and during the same vertebral angiogram we saw from PCOM the internal carotid artery up to the proximal part of internal carotid artery, and distal CCA was filling retrogradely. So we initially thought like we'll defer the procedure. We didn't plan anything on the same day. Then subsequently repeat CT angiogram was done after 2 days. That also confirmed the same occlusion from the proximal CCA. So, but patient was on conservative management. Then after 4 days from the IC test, patient had another massive hematemesis with a tracheostomy site bleed of about 1000 ml. So patient was taken up for DSA. So we thought that it's because of the retrograde filling of the ICA from the PCOM, there could have been a bleed. So we thought we will try to reach the proximal ICA and distal CCA retrogradely, and we took a 8F short sheet access. Then following which we placed the seribase at the V1 segment of the vertebral artery, and then we navigated the seriglide up to basilar top, just short of the basilar top. Then we used a rebar microcatheter and a synchro wire to reach ICA. So this is these are the markers of the microcatheter, and then we reached up to that thrombus point. Distal end of the occlusion point, and then from there we started coiling with the 2 coils, 1130 and 1030 optima bolt. We have occluded proximal ICA, distal CCA, and ECA origin was also jailed by the coiling. And after that we thought like we will put one more coil here in the proximal occlusion site, which like after that we felt that it may not be necessary because it was only retrograde filling. But during the coil deployment there was no issue, but after detaching the coil and after taking the contrast injection, there was a migration into the subclavian artery, and immediately the coil was snapped out and it was left. We did not do anything, and after that till recently patient was not having any further bleeding. Complete hemostasis was achieved, and patient was recovering well, now undergoing treatment for the thyroid CA. And this is the second case where a 55-year-old female who presented with sudden onset severe headache and immediate unconsciousness. There was a SAH, bilateral sulcal spaces and Sylvian cisterns, and there was a 3 by 3 millimeter aneurysm from the ACOM artery. It was a relatively narrow-necked aneurysm, which we found out in the angiogram, initial angiogram. So routine angiogram mapping and was done, and then coiling was planned. during the time of the coiling, I couldn't save that image actually. There was wire was going behind the confines of the aneurysm, and could see in the negative roadmap the positive blood was slightly leaking. So immediately we identified the rupture, and the heparin was reversed completely, and wire was not removed from the site of rupture, and immediately rapid coiling was done to deploy to secure the dome of the aneurysm, and this is the post coiling. And following day, on the same day of the coiling, when CT was taken, there was slight increase in the SAH across the sulcal spaces, and there were minimal IVH was also noted. And patient had a deteriorating GCS. Patient went to from E4 M5. Patient went to E2 M1 on the day after the procedure. Immediately EVD placement was done in view of rising intracranial pressure. And then patient had a very stormy course of about 3 weeks to 1 month in the ICU itself, with intubation followed by tracheostomy placement. And in the final angiogram, the final CT, the SAH all resolved, and patient was discharged with some deficits. She went with E3 V4 M5 status with the GCS of 12 with the tracheostomy in situ. So if time permits, one more case. So this is a 20-year-old male who presented with 1 month duration of progressive symptoms with severe abdominal pain and marked abdominal distension and clinical jaundice. So diagnosis was acute Budd-Chiari syndrome. Hepatic veins were not visible in the CT. However, in the ultrasound we could trace the hepatic veins. Only in the hepatic vein IVC junction we couldn't see flow in the ultrasound, and this is the flip-flop pattern seen in the CT. So we tried from IJV route, but we couldn't cross the occlusion. So initially we thought we'll try to open up the middle hepatic vein first. So we took a transhepatic access using a 7 French sheath into the middle hepatic vein directly, and from transhepatic access we were able to cross the middle hepatic vein, and we did 8 mm balloon plasty, and following which we placed a balloon mounted stent, 8 by 37 balloon mounted stent was placed across the thing, and flow was restored. And this was the stent was seen partly, and this was the decongestion happened after balloon placement, stent placement in the liver. And there was a significant reduction in the ascites, and patient also recovered well. Then we thought, like, since he is only 20 years old, 1 week later staged RHV also was attempted for stenting. And the same way from IJV we couldn't, this was the previous stent, from IJV we couldn't enter the right hepatic vein, it was difficult, so we took a RHV access directly, and then same way plasty was done, and the 8 by 27 stent was placed across the right hepatic vein. And this is the final CT picture post middle hepatic vein and right hepatic vein stent placements. Thank you so much.
Very nice cases. I had 2 doubts regarding the first case and the last case. In the first case, you went through the PCOM route. Suppose the PCOMs are not good enough to take a rebirth catheter. What were your alternate?
Other option was ACOM, sir, but ACOM was also ACOM was very small, and PCOM was slightly bigger. In the previous angiograms what we have done, we realized that PCOM was slightly bigger, so that's why we took the PCOM route. Other option would be ACOM. We antegradely we tried to cross the occlusion also, but initially we attempted with a balloon guide catheter placed in the proximal CCA and tried to cross the occlusion, but I couldn't cross the occlusion, so that's why I had to take the retrograde route, sir.
The aneurysm was from the CC or ICA?
The pseudoaneurysm was from the distal CCA, but it got completely occluded. The next day while taking up for angiogram, it got completely occluded from the origin.
Were you thinking of puncturing the ECA branches and come retrogradely?
We have jailed, in coiling only, that's why we have jailed the ECA origin also, so that the retrograde collaterals from ECA may not fill the distal CCA.
Accessing a STA branch or coming?
Yeah, ECA, we didn't consider that, probably we could have considered ECA access.
The last case, a 20-year-old with acute Budd-Chiari, why not an anticoagulation only?
Anticoagulation was started before the procedure itself.
No,
but
why not only anticoagulation?
Yes.
What made you think to revascularize the hepatic vein was he going for hepatic encephalopathy or acute liver failure?
No, he was not going for hepatic encephalopathy, but liver enzyme started rising, sir. Liver enzyme were increased significantly. It was in the range of thousands, despite starting the anticoagulant therapy. So, the immediate post-stenting, liver enzymes started falling, and after both the stents placement, liver enzymes became normal, sir. So that is why.
So he was not responding to anticoagulation.
Anticoagulation, refractory to anticoagulation, that's why.
And HE was not started.
HE was not started, sir.
And any mutation analysis was done for the patient?
They have sent it, it to be followed up, sir. All protein C, protein S, factor V Leiden have been sent.
mutation and things.
But we were told that initially mutation analysis came negative actually. They were working up for other procoagulant states actually. And he was put on anticoagulation. Post procedure he was put on he was continuing the anticoagulation actually.
Because 20-year-old patient with acute Budd-Chiari, one is JAK mutation, second is PNH. Because these two are the, you must be put on long term. If it is PNH, you must put on an antiplatelet load. So that's.
Antiplatelet.
I thank Shantakumar for his contribution to this alumni meet. I welcome Dr. Vinayagamani, the next speaker. He is a proud alumni of SCTIMST IS&IR. He joined for DM Neuro Interventional Radiology in 2017, and he is currently working as a senior consultant in intervention radiology in Hannah Joseph Hospital, Madurai. I welcome Dr. Vinayagamani to deliver his talk.
Sir, so first of all I would like to thank the faculties and my teachers for this opportunity, and I thank it's an honor to present in front of legends and teachers, faculties. So I will be presenting two interesting cases. So one is first is an aneurysm. Both are giant fish-saccular aneurysm deferred by the neurosurgery team. So this is the first case. In 2015, patient has been clipped. It's a 42-year-old male. So after clipping, there is a progressive recurrence in the giant partial thrombosed fish-saccular aneurysm. So he had a headache, but he was not managed. He was followed up, and he started developing embolic stroke. So he was started on dual antiplatelet therapy. So this was the embolic event which happened in the left MCA territory. So this MRI has been done after 10 years of surgery, where we can able to see the clip is displaced anteriorly, and we can see the multiple embolic infarcts. So now this MRI shows that there is an edema in the left temporal lobe because of the compressive effect of the aneurysm, and then we can see the blooming artifact in the anterior to the MCA, which is due to the displaced surgical clip. So because of the recurrent embolic event and partially thrombosed aneurysm, so we decided to treat. So the first option we kept was surgical option for bypass and trapping, but however patient had a surgical risk, high surgical risk, and also a patient already has been operated, so he is not willing for another surgery. So this has been referred for this one. So this was another MRI with recurrence with antiplatelet, dual antiplatelet. Patient developed another embolic stroke. So we decided to treat with flow diverter assisted coiling in view of thromboembolic presentation. So this was the DSA, which was showing dissecting aneurysm, fusisaccular, partially thrombosed, displaced surgical clip anterior to the aneurysm. So here the narrowing is because of reduced flow due to the proximal dissection. So we have planned like flow diverter assisted coiling by complex reconstruction of the aneurysm. So this is the AP view and working angle view showing the fusisaccular aneurysm with partial thrombus. So we have crossed this aneurysm with good distal support, and then we have straightened the wire, and we have loaded the flow diverter, and we have jailed the microcatheter, and we have completed the coiling in the inferior aspect of the aneurysm. So after that, deploying the flow diverter, this was the injection. The flow was good across the stent and the coil was good. So this was the final angiogram. This was the vaso-CT showing good stent apposition, and there is a anteriorly displaced clip. So this patient extubated immediately after the procedure with a full GCS. He doesn't have any further neurological deficits. So post-op, he was doing very well. His ischemic symptoms are not there in the 3 months follow-up. And this was the follow-up MRI. So this is like, it's like a case which I want to highlight, like overcoming the prior failure and hemodynamic synergy and anatomical preservation of MCA branches. This was the follow-up MRI of the patient. Patient currently doing well. So we can see, since it's 3 months only, we did only MRI, planned for angiogram after 6 months. So we can see the complete flow modulation of the aneurysm and complete absence and the coil and the normal flow. So this is an axial view showing complete occlusion of the aneurysm, and patient is doing well. So similar companion case, again patient present with embolic phenomena, and this is a giant fusosaccular aneurysm with reduced right side distal antegrade flow because of the steel. So again this patient is a revender, and I told surgical bypass with this will be the first option because dual antiplatelet issues are there. But anyway he had a CAD, he have to continue antiplatelets. He also had an ischemic presentation, so surgery option considered risky. So we went again with the complex aneurysmal reconstruction with flow diverter assisted coiling. So here we deployed Silquista and Jade, and we did a loose coiling to prevent accelerated thrombosis. And this was the angio final procedure after completing the flow diverter with coiling. This is the vaso-CT showing normal stent apposition. We started dual antiplatelet with heparin for 5 days to prevent accelerated thrombosis. Luckily aneurysm didn't re-rupture. It doesn't have an embolic phenomenon. This is a follow-up MRI. Again thrombosis is there, distal flow is good. Here in the top we can see the flow diverter in the right MCA region showing normal flow, and 3 months patient is doing well. His MRS is 1. So we have to do a DSA after 6 months to see the flow modulation result. So this is the so both are thromboembolic giant fusosaccular aneurysm denied by neurosurgery and failed by clipping. So we did a flow diverter assisted coiling. This is the second case where it's a 33-year-old male, no comorbidities, present with headache, low GCS, intubated with 2T, SIH with ICH. Outside they have reported as vascular malformation. So when we reviewed the CT, we found out this could be a aneurysm or AV fistula. Perimesencephalic subarachnoid hemorrhage is there. A well-defined rounded hyperdense structure in the right side of the perimesencephalic system, which is causing edema around the midbrain. So after EVD, the GCS improved to 5T. That's the reason why we have planned for the treatment. So when we did a DSA after this is an MRI, baseline MRI. We can see the edema in the right midbrain, right hemi-midbrain, and multiple small diffusion hyperintensities and intraventricular hemorrhage. So this was the baseline FLAIR MRI showing the edema in the right side of the midbrain and also subarachnoid hemorrhage and intraventricular hemorrhage. So when we did a angio, we found out there is a vascular malformation. So we can see in the cerebellum venous congestion is there, which is again indicating there is venous hypertension, and that is the reason why the patient bled. So we did a DSA. DSA showed cogna type 4 right lateral tentorial dural fistula, and we can see a venous aneurysm in the Rosenthal vein with reflex into the parenchymal veins. So possible cause of rupture would be the venous sac rupture due to venous hypertension. So both ECA feeders and ICA feeders are there. So this has been missed for years. So now it presented with bleed. Right ECA feeders. This is the angiogram showing the filling of the venous aneurysm and the reflex. So first plan is transarterial pressure cooker to occlude the fistula, and backup transvenous if we couldn't occlude the fistula through transarterial. So first we kept the microcatheter, we put a coil, and with the pressure cooker we able to inject the squid, and we could achieve at least 70% obliteration of the network. But after that, still the fistula is filling via ICA branches. So the concern is again if the venous sac ruptures, his GCS will go from 6 to again bad. So we have to go for transvenous access to completely obliterate the residual fistula. That's our concern. So we took a transvenous access and we entered into the basal vein of Rosenthal and then we just coiled it, coiled the sac as well as the fistulous point, and then after putting the coil, we injected little amount of squid to completely obliterate the fistula. So after the obliterating the fistula, we did a check angiogram. There is complete obliteration of dural AV fistula, and the venous sac is also completely thrombosed, and the other branches showed maintained perfusion, no branch defect, etc. So what we found is the post-op CT is same as pre-op CT, coil mass is there in the venous sac, hemorrhage is almost same, no infarct, everything. The patient had a same persistent GCS of 60. So this was the squid cast and the coil cast exactly in the fistulous point. We had a one reflex into the cerebellar vein, but that is actually the not having a normal hemispheric drainage, so it's not clinically significant. So this was the axial view. So when we did a follow-up MRI, what we found was the edema is there, but there is no venous infarct. The GCS is same. So you can see the edema is same, and patient IVH and SIH is resolving. So 2 weeks post-op MRI, because the patient has no improvement in GCS, we again did an MRI, and what we found is venous system are normal. There is no deep venous thrombosis, there is no significant involvement of branch veins, but a perfusion is fine, edema is also same. So, but this patient had a persistent GCS till 580/15. Even though there is angiographic cure, the clinical outcome is poor. So, but we have already discussed the prognosis because of venous hypertension and the mass effect in the brainstem. We told that patient will have guarded prognosis. So, what we conclude from this is it's a dual-edged pathology. Hemodynamic cure in this case will not successfully translate into clinical recovery, and the thrombosis risk as well as the mass effect in the brainstem pathways, brainstem edema, made persistent depression of RAS system and irreversible brainstem edema. And one of the reason is chronic compression, venous congestion and venous hypertension. So other option is I don't know, but in few case reports they have told decompressive strategies can be done, but the patient already had already the clinical condition is poor. So we didn't give this option. This is all the similar cases where there is a brainstem reflex, brainstem venous hypertension and edema. So learning point in this, hemodynamic cure is not a clinical recovery. So here the venous aneurysm is the reason for poor clinical outcome, and here we found that brainstem edema is not always reversible, and this persistent mechanical compression led to poor outcome despite treatment. So what I felt is the early diagnosis and early radiological awareness will definitely improve the clinical outcome in this kind of tough cases. Thank you. So already was there, sir, and that improved the GCS also. That's why we planned for a treatment, but the GCS was same, it was not improving.
Again, nice cases when I. So in the second case, because the dural AV fistula is usually underdiagnosed, and
yes,
it's almost there is a latency of 4-5 years before you
yes,
diagnose properly. Was it a medial tendoral, lateral tendoral type of a?
sir, it was more of medial tendoral.
Medial
Yes, sir. Yes, sir.
Because so you came through the venous approach, a pile venous approach. No?
Yes, sir.
So suppose you have an SPS or an IPS is there, would you prefer the dural venous retro approach or a pile venous retrograde approach in this?
Sir, in the initial venogram, this vein, when we did a angiogram, there is no much of hemispheric face we could see the return. So we thought sacrificing this will be easy. So assessing this, I thought this route is easy. That's why I went through this.
And how much risk was there a cranial nerve palsy for that extradural arterial embolization?
Pardon, sir?
Initially you went through the arterial embolization.
Yes, sir.
So how much risk was there for a cranial nerve deficit in procedure?
Yes, sir. It's there. Because we are using squid, 10 to 12% risk is there. But we went distally and we just targeted the network. Tried to prevent the reflex. So we just put a coil to prevent the reflex and then we injected. Sir.
And the non-resolution of brainstem edema, is it due to the mass effect of the coil or something else? Or thrombosis?
Sir, we did a serial MRI where we see the edema is same, but definitely even though MRI it is not showing, thrombosis would definitely increase the mass effect. But usually by 2 to 3 months it should settle. This patient was at in tracheostomy MRS for 3 months, but his DCS was not improved. So what we found is this persistent compression would have caused venous congestion and micro injury because of venous hypertension. Although we expect it should shrink after 3 months.
And in the first case, the MC aneurysm, you are extending to the M1 territory. So will you, what is the number of braids you prefer, 64 or 48 for that? Flow diode, how many braided?
Yes, 64, sir. We compacted at the neck also to improve the flow diversion.
Okay.
Next case we didn't compact because we don't want rapid flow diversion, accelerated thrombosis, because the first case is partially thrombosed. Rupture risk is less compared to the second case.
So do you think that for a 64 braid, is there a risk of a perforator involvement in fact because you extended to M1 territory?
Yes, sir. Here, the braided, the risk is more with more braiding, but luckily dual antiplatelets and this one and statin prevented, sir. But almost there is a risk, but this patient, that's why we told to go for surgery, but they also told the perforator risk is there, trapping, there is no collateral, so that's why we have to take this with the risk we did it, sir. But luckily patient is doing well.
Thank you, sir. So thanking all the presenters for sharing such wonderful cases with us. I'd like to invite Dr. Suresh Nair, who is the professor and former HOD of Neurosurgery Department of our institute, to hand over the certificate of appreciation to Dr. Jayakrishnan. Thank you, Suresh Nair, sir. Next, I would like to invite Dr. Krishnan, who is a professor and former chief of vascular surgery of our institute, to come over the stage to hand over the certificate of appreciation to Dr. Shanta Kumar. I would like to invite Dr. Periya Karuppan, sir, professor from Omandura Medical College, to hand over the certificate of appreciation to Dr. Vinayaka Mani.